Thanks, Belinda. That was terrific. A great distillation and summary. So we have time for conversation as a big group and questions for Melinda. We are going to break, just to note and to, for your comments. We are going to break into two groups after this and go into kind of the so what and deal with these in conversation. So, but if people want to have questions, we do have some time for folks now. And Terry, let's start. I think I left you hanging on the last one, so let's start here and then we'll.
That was so terrific, Melinda. And one of the questions I have is, do you think we're moving toward a common? Do you think we're moving toward a common definition in the room or in our work around what chronic disease is? So people are saying chronic disease, and I heard Dr. Jha say 9, which was promising to me because at least that narrows it a little bit. But do you think we're moving toward that? That's the first one. And second, I want to thank you for that more generous comment about this term called compliance adherence. I think your new model, it gives us a lot to think about. Thank you. Go ahead.
I think Ashish and Jerry could respond a little bit better on the common definition of chronic. I do think the work that Yale did, that Ashish built on and adapted to come up with the major complex, minor complex, simple complex is very compelling. I mean, I have to say I love it, but I did also recognize as when we looked over the program literature, how and started talking to people that maybe 3 was too many. From the social marketers, they say, by the way, that you should have 5 segments and no more. That more than 5 is too much. And I think it's really interesting, by the way, that Bellin had 4, and I think, again, it kind of depends. So I don't know if we're reaching a common definition, but I do think it would be great to have reach some consensus on definition of very high need patients, the core segments and what drives both the needs and the costs within those segments, and have some understanding of major complex. And Joanne Lynn's work, which is really seminal, thoughtful work that in this whole space of segmentation, talked about people who were kind of stable versus unstable. So when I look at the major complex chronic, I think like those are people who are really struggling to kind of keep their multiple conditions and really complex conditions in a stable way. So I don't know. Ashish, did you have anything you want to add?
You can add and then pivot right to your question. Would be great.
So I'll add and pivot, and it'll all seem perfectly seamless. So I think, so first of all, I love what you've done with our initial approach. And if I knew that the social marketers said no more than 5, we would have come up with 5. But the big picture point I want to make is that I think we should tolerate a certain amount of dissonance and discordance on this stuff. I don't actually think we would serve ourselves well if we walked out saying, okay, we've got the segments, here they are. Because we all have different uses for them. We want to think about them a little differently. And what we want to do is, to the extent that we disagree with each other, and again, I like a little bit of disagreement, we should just understand why. So people should say, okay, you know what, we're not going to split the chronic disease, people with chronic disease into 3 groups. I'm going to do 2, and here's why, and here's what I lose by doing that, here's what I gain by doing that. And if we can walk out with that level of understanding, I think it's fantastic. One of the risks that I think we do fall into with this, and we thought about this because we obviously came up with an initial iteration, as you know, Melinda, because you were with us at every step. We've iterated multiple times. I feel like we've gotten better at each iteration, but I am not convinced that we're done yet. And if we kept iterating, we'd probably do it a little differently a year from now. That's okay. I just think a certain amount of disagreement, a certain amount of divergence is going to be healthy for all of us as long as we're clear on why we're doing it. And to Terry's point, I do think that we have to think about chronic disease in a more subtle form. Almost everybody has a chronic illness coded somewhere in their claims data. That's not useful. And it really is different if you have heart failure versus if you have hyperlipidemia. And so again, the Yale group has done terrific work on this. We modified it a little bit because we're Harvard, can't go with the Yale approach. But I think we are getting to some level of understanding about how to think about chronic disease a little bit.
I concur that we do not need to walk away with one typology. I think it would be a huge win as a result of this Peterson project if we could get some agreement that, hey, it's a heterogeneous population and we need to think about segmentation. Here's a variety of approaches.
And we're going to have lots of time to wrestle that one in this. We're going to do let's see, 5 comments here, and then we'll break into small groups. So let's do David, Don, Peter, Diane, and then we have one more up over here, Simon. So we can do these. Let's do 2 at a time in terms of to move us. So David, then Don, then Peter, Diane. Actually, we'll do 3 then. Peter, Diane, and Simon. Okay?
So I'm going to be very brief. So your comment about this is not ready for frontline providers, I think is true. On the other hand, I think that there is a responsibility of this group to think about the value of these that come to patients and their families directly and to frontline providers. I talk about primary care because most people go to primary care first and they have ongoing relationships with them. And as we've worked with them to do risk stratification, the value of the risk stratification or segmentation technique really depends on their interpretation, understanding of it, and its ability to affect what they do with patients. Like, is this a segment where they think, yeah, there's amenability to change, as you say, or is there an opportunity to do something to reduce my cognitive load because there's so much data and information about these patients, I can't integrate it into my clinical intuition easily. And I think that responsibility to keep on iterating to those groups is really important. And so, maybe you can comment on that or sort of think about that.
Don, you can go.
So I really liked something you slipped in pretty quickly around persona and marketing behavioral segments. I think it's a really fertile area because it gets much closer to the needs and perceptions of patients and things like utilization and cost. And I'd love to see that built out. Ultimately, we're going to need to engage patients in these segments with our programs, and that's really the window to doing that effectively. And secondly, I think I've died and gone to heaven. I introduced myself intentionally as being from Boston Children's Hospital because I assumed that children would again be left out of the dialogue of high-need patients, but they're very well represented here. I do have one suggestion. By making them a separate segment, we acknowledge that kids really are different. I think that that's very, very important. On the other hand, some of the best models for coordinated continuity of care for high needs patients are in pediatrics, be they at National Children's or Boston Children's, Cincinnati Children's, or wherever. And I haven't seen a lot of research being done to see what lessons learned from children could be applied to adults, especially to elders.
It's a great point. So, Dave, to your point, I think it's just more my nervousness slightly, my anxiety about presenting this, that I'm like, this isn't supposed to be immediately relevant on the front lines. Now, if it has no relevance to the front line, then we've also kind of failed. So I think I kind of overstated the limitation, meant more like I'm not so sure you could kind of hand this over. But I think you're absolutely right. I mean, the truth is a body like this one that is thinking through these issues, if it needs to at some point as it goes forward, think about its relevance and application to those, whether it's either at the leadership level, which is where we were focused at our foundation, but also maybe the manager level and the provider level. And absolutely, that is where we need to go. So I think I probably overstated it. And yes, I'm happy that we're doing personas and focus groups and things like that. To be continued.
So Peter and Diane.
Diane Stewart, PBGH. I really like the framework that you've laid out here. I wanted to just confirm and maybe reinforce who the customer is for this work. And what I heard you say is it's delivery system leadership. And if that's true, then I think the next thing they would do with it is sort of a population analysis to find out for their organization how many they have in each of those boxes. Yeah. And after working with 24 organizations in this area, I think that's a very helpful framework to offer. So I think this is, and what I like about it in particular, regardless of business line, if you're a safety net Medi-Cal provider in California, Medicare, a commercial, I think it looks to me like it's applicable across multiple delivery systems and multiple business lines. Thank you.
Great.
So I also like the idea of identifying the patient's needs as the starting place, which is what this presentation is about. I've been a residentialist, Greg, since 1984, so I'm happy to have a new name. And I wanted to make a couple of remarks from the framework of the Independence at Home demonstration, which many of you may have heard about, targeting a home-based delivery care model for patients who have both severe chronic illness and functional impairment, which was mentioned in the early going. I'm a geriatrician, so this is more about Medicare frail patients than about the other populations, though I think probably has some application more broadly. So using simple criteria, specifically prior hospitalization and use of post-acute care along with functional impairment, that demonstration was able to identify a very high cost, high utilization group. And then the preliminary results look like there's been some fairly substantial success in modifying the utilization curve with measures of patient satisfaction being met. So this is about segmentation. I'm going to say we have some available data that are not too complicated, so we don't have to spend decades sort of analyzing it before we can start moving forward, and suggest that we can look at that as a potential framework.
Simon Hambidge, Denver Health. I don't want to keep harping on the pediatric theme, but I just had a couple thoughts. One was that one risk of having a box with children with special health care needs is that for folks who are overseeing systems that care for kids and adults, they think that's the only pediatric box. And I think the challenge is with the other boxes that, well, complex chronic conditions, I mean, where does asthma fit in? You know, and so you almost need to do a sub stratification within some of those boxes. Otherwise, you won't necessarily hit kids with asthma, for instance. Just along those lines, I think what we've seen across all pediatric utilization in all the tiers is the impact of behavioral health. Kids with chronic needs, it's huge, but it's huge for all kids. And so I really like the way you had that laid out at the bottom, but if we don't address that, then we're missing out on a lot of opportunity.
So one of the things about Denver's approach and Joanne Lynn's paper from 2007 is you were segmenting the whole population. So that's why, so you're right. In this, even if we were a little more sophisticated in around the kids with complex needs, your child with asthma wouldn't necessarily show up. We were a little bit, we were starting with those who were kind of high need, what we call high need, high cost. So, and I think that that's just another choice, that if you're a system, I'm trying to segment my entire population. So, the maternal and child health and those that, because you move through with the life course. I mean, Neil Halfon's work and the trajectory. I mean, absolutely. So, but I think that this work was limited in that way, and I think that's a valid critique of what we've got.
This is great work, Melinda. I just wanted to add on to that. I follow a very big population and do population segmentation, and another group you might want to consider is less than 65 without chronic condition and without disability. So in my market, because I look at everyone, and they don't show up in the Medicare data. They also don't completely show up in the Medicaid data because they're on and off. They get fired from insurance products. But if you look at population from a person-centered perspective, there's behavioral health, substance use, and then also economics driven. Yeah. So people that have high frequency ED for sale of narcotics that they're receiving from the ED.
Great. Yeah.
Great. Any last word for the big group? We're going to break into our first breakout session. Thank you, Melinda. Okay.